Now I can say the same thing again.
Yes, thank you.
Welcome back to the new year. Thank you all for coming today. I'm really excited by the turnout we've got for the first meeting of the year. First things, if we could, has everybody had a chance to review the December minutes? I had one correction that was supposed to have gotten into the minutes for initial review, and it didn't, which is that the TXA or succinic acid was approved for helicopter agencies, not just for LifeNet. And I had asked if that correction could be made by staff here. Are there any other corrections? I have a motion for approval of the minutes. Second. All in favor? Anybody? Dr. Bosco sitting on his hands up. All right. Folks that are excused, Dr. Duthaler, Dr. Vogel, Dr. Funk. Dr. Funk apologizes. She will continually have child care issues. Staff here is still going to work to find best times available for everybody to see whether or not we continue on Wednesdays or whether there's a better time.
Might as well add Dr. McHugh to that list.
And Dr. McHugh. Also excused. We have a notice from NISC unit that Jim Venna is going to be the new quality assurance coordinator, which is good luck to Jim there. He also serves as a member of the council and has been doing a great job with us at the state council, which is nice. We have agency deactivations. A little bit of discussion about the lorazepam issue. Doesn't affect us as an agency, as a region, because lorazepam is not currently on our formulary, but is of grave concern given the number of benzodiazepine shortages that we've seen over the course of the last couple of years. Mike, I don't know if you want to speak to it at all.
I mean, I don't know what you want me to speak to. I mean, it's always a possibility that we may need to utilize it here at some point if we exhaust our, our preferred benzodiazepine, which is the Dayslam right now. I think it's something we're going to need to continue, look at a case-by-case basis. The whole drug shortage thing just kind of disgusts me. I don't know what other feeling to have other than disgust, because I don't know what to do. And I know dopamine and atropine seem to be the issues now too with a lot of local agencies.
Yeah, dopamine and atropine, and that'll be coming up a little bit later for discussion as well. The conversation actually I had with Lee, and I also had with Mr. O'Leary, Terry O'Leary, who's the chairman of director of the Bureau of Narcotics Enforcement, former prosecutor from New York City, extremely nice guy, was basically, they were asked to look at a number of controlled substance plans, saw lorazepam on there, which had never been put on a state formulary before, although it had been approved in regional formularies before. So it just hadn't been updated to the state formulary. When their pharmacists started looking at the lorazepam, they suddenly realized this is not a temperature-stable drug. They're taking this drug into an unstable temperature environment. What then will happen with the drug efficacy? They called the FDA. The FDA said, well, we can't say that it'll still be any good. And without the ability for the FDA or one of the manufacturers of the medication to step up and say the drug is good for 15, 30, 60, 90 days out of refrigeration, they had to issue the letter that they did, that if it's not under refrigeration, it won't be able to be used. So that was an interesting, very interesting process to see how that all took place.
I was involved with that process, and I can tell you that the problem was not that no one would give us. Manufacturers would say, ours is good for 30 days, 60, 90. There was no consistency, and because of the drug shortages, they could not guarantee who the supplier would be. Primarily used in the Long Island area, Nassau, Suffolk counties.
Yeah, particularly I think out in Suffolk, and it also, interestingly, is one of the drugs that came up as we were talking with Hudson Valley, because Hudson Valley has it in their formulary as well. So, interesting perspective. As we looked at the evidence here, midazolam very clearly is a better drug for the things that we use benzodiazepines for in the pre-hospital environment, and the fact that it's temperature stable makes it even better. So, we're heading in the right direction as long as we don't get sidelined by another one of these drug shortages, which of course Mike, being the pessimist that he is expecting at any time. Mohawk's Specialty Care Transport Group is up and running. Let's start with committee reports from academic first, please. Dr. Doyna.
Okay, meeting, basically, majority of it was discussing membership. John, since you're the membership committee person, I don't know if you just want to make a quick comment about it.
The membership was revised as of January 1st. Voting members have changed for this current year, and there's a new member appointed, and that's about it.
So essentially what occurred, people had not made 2/3 of the meetings. They became non-voting members is probably the best way to put it. The thought being that we need to somewhat control who would come and vote and not vote, because at times we have folks just show up and vote and then disappear again. People who are non-voting members certainly can apply to be voting members again, and hopefully those non-voting members will continue to come and contribute, because we do appreciate everything that they've done for all the years that they've been here. Mike gave a nice update on a lot of statistics in the area, which was interesting. I don't know, Mike, if you want to comment at all on what you talked about?
Well, actually, what I'll do is let me share the brief presentation here. It'll be redundant for the people who were in the room before, but I'll just buzz quickly through to a couple of the slides for the physicians. As most of you know, we collect statistics on ALS procedures through the ALS.com website. This is set up through the office here, and then after each call, a provider logs on and gets a signal number that ultimately is the authority for provision of the ALS. What this ultimately does, well,
Yeah, sorry.
I'll push this, I'll just point this at you.
Yeah, that's not gonna work. Interesting, because it's on my screen over here, and it's not over there. That's pretty cool. So, we're gonna do this.
You want to advance the slides for me?
Yeah, let's do that.
Okay.
Let me see if I can do it. Hang on.
Well, this is what the title slide looks like.
Don't do anything.
Keep going. All right. So this is actually a slide that led to some interesting discussion. This is a comparison between the total number of signals or advanced life support calls that we do as a breakdown to what gets medical control and what doesn't. We know as we've moved to more standing orders, particularly around the pain management, that we've decreased the number of contacts with physicians. The interesting thing will be is now we have to go back and audit our taped line and see, do we have accurate information here as terms of the total number of calls or not? There may be a discrepancy there, and we'll check on that through the office and find out. But I find it very interesting that between 2009 and 2012, we've dropped about 1,600 calls from medical control to standing orders, which is very interesting in terms of utilization of the physician time. And there have been nothing that I have heard as a result of detrimental effect to our patients as a result of that. I'll keep going right past that. We looked at medical and trauma calls and mechanisms, and this may not be something that we ultimately need to collect from this source. This may be something that's better off collected through other sources of reporting, such as directly from the PCRs if we can. Intubation information. I have to start this by saying that successes and fails. Fails is actually not a failed intubation. It's a failed attempt. So this actually should be reported out a little bit differently, which it should be how many first pass, second pass, third pass attempts there were, or changes over to an alternative airway. So the way the data is being collected and reported is difficult. The interesting thing is there was just a paper presented at the Society for Critical Care Medicine which talked about in-hospital success rates. It was actually talking about the difference between etomidate and ketamine as induction agents, and they happened to report that they had between 70 and 80% success rate on first pass in-hospital intubations. This, while it's showing us at 69 or 68%, isn't really able to show us that piece of information. We're going to try to tease that out. Last time we looked at the data, that's about where we were. And there is nothing that tells us exactly what an in-house success rate is, which is interesting. IV
Before you move on
placement.
there too, one other
Please.
thing would be a confounder just while you're going to be redoing it. some agencies in cardiac arrest are going directly to using something like a king rather than even planning on doing an intratracheal airway, which is not an unreasonable approach, but I wouldn't want that to skew your numbers in considering that a fail, when in fact that was an intentional.
It should just be reported separately. Yeah, I agree. Under IVs, it's interesting to see the progression of number of IOs going up and now maybe getting some sort of stability in 2011 and 12 at the 650, 679. IV attempts and successes, again, we've got a percentage of about 70%. Among the things that were mentioned by members of the academic committee as we went through this doesn't necessarily give us a good piece of information because, again, we don't know what the right baseline is. You know, are there some providers who will look at a patient and say, there's no way I'm going to get them, so I'm not going to start an IV? And others who look at the same patient and say, that patient needs a fluid bolus, therefore I have to get an IV. So the more aggressive provider may try 4 times on that patient, the less aggressive person may not try at all. So what ultimately is going to give us the right number at the end of the day, I don't know. This one is more just an interesting piece of information than anything else. And again, not giving us first pass, second pass, third pass. This number was actually very bizarre. From what I can see of STEMI data on a regional basis, there were not 400 STEMIs in the region last year that I have seen through any of the data, but it looks as though there were 400 STEMIs transported. I don't know how many of those may have been recorded, double recorded, so that's something else that we have to ultimately tease out. It is interesting that we got 16,000 EKGs last year. We have at this point, I believe, about 8,000 EKGs in a bank. This is all the EKGs that have been transmitted since we started the transmission system. If anybody has a project that they would like to do from a quality assurance standpoint looking at all of those, let's bring it to this group, review it, and we can talk about whether or not it's something we should do as a regional project. So I think it'd be a really neat idea. And then NARC utilization. This is something that when Deb Cuffs first reviewed the quality assurance data of our narcotics, we actually had a discrepancy that guys got narcotics more frequently than women did. That was easy. The girls all said that the guys are wimps, and the guys agreed. On the other hand, as time has passed, we've seen this equal out, and actually men and women get drugs about the same. It's nice to see that we don't have gender discrepancy. A little bit of an interesting discrepancy in that medical patients get narcotics more frequently than trauma patients. Just interesting information. And then utilization by type, again, standing orders versus medical control. We can see that there are less use of medical control using morphine, probably because our providers are more comfortable with it. There aren't that many doses of morphine given to children, so that wouldn't support the reason all by itself. So remember, we can give morphine to kids on standing orders. We can't do that with fentanyl. So, interesting information. And our range by age, which for the future, what we'll do is we'll look at this superimposed on the bell curve of our age distribution for our patient population. But this, just by review, is probably pretty close to the age distribution of our patient population anyway. But it'd be interesting to see whether or not there's actually a discrepancy between age distribution here and the distribution of patients we take care of. And then looking at kids themselves, it's very interesting. We very, very infrequently give controls to kids between the ages of 4 and 8. And these kids get hurt. So very interesting to find out how many of these kids are getting hurt. We're just not taking care of their pain for whatever reasons. So just a quick update without spending a lot of time on any of it. Any questions or thoughts from the group? Remo ALS was designed as a relatively living process, so if there was something that anybody wanted to change, so we could look at this on a more regular basis or look at it asking the questions differently, that's something we can bring together, we can talk about in order to look at the questions differently. Okay. Good, thank you. Don, you good?
Okay, that's basically it.
CMAC. The CMAC. I'll speak briefly about the CMAC. I wish I had Carol's notes, they were beautiful. CMAC approved a couple of interesting protocols. The most interesting one was some protocols that came out of the City of New York, which would be physician-driven, or on-scene physician-driven paramedic protocols, which is kind of strange because they're all going to be guided by the physician who's right there controlling much of care. But they included very liberal use of ketamine, as well as the use of TXA, both of which have the possibility of showing up as we continue to review things for the future. They were interesting to see. There were a couple of other protocols that were approved ultimately with a lot of discussion. One was the Central New York protocols, which look very, very much like ours, although they changed some of the colors around, so they're a little bit different. And then there was a lot of discussion around a move to motion that every ALS agency in New York State would be required to have controlled substances. Not an unreasonable thing. I see a lot of nodding heads. These heads in this room should nod. We've had that policy here since 2004. It's the right thing to do for our patients. That's why the motion was actually made by Dr. Broderick from Mountain Lakes and myself. It's just the right thing to do. The CMAC passed this with only one dissension, and then it was tabled at the SEMSCO because they wanted it to go into a couple of other committees on the way, which was just kind of an entertaining process. Rich Brandt made a very eloquent plea for it to be discussed at that point, and he was voted down, but it was very entertaining to get a chance to watch it. Carol, do you have anything else to add?
No, not really. That was pretty much the highlight.
Okay. Anything else from the SEMSCO that you want to talk about?
No, not much. Lee Burns did give a report on the Hurricane Sandy response, which she was very much impressed. She was down in New York City for about 10 days, and they managed to evacuate 40 healthcare facilities, including 6 hospitals, which if it ever happened in this region, I don't know what we would do. They did use the National Ambulance Contract, which allows for ambulances to be called in from all over the country, and they were able to respond 360 ambulances in very short order and evacuate those facilities. So she thought that was absolutely amazing. So they're going to work to formalize some more of the processes and utilizing that, but that was pretty much the highlight of that. Other than that, the EMS Memorial is going to be held on May 21st at 11 a.m. down at the Empire State Plaza if anybody wants to go to that. They are inducting 2 names onto the memorial. And apparently also during the Hurricane Sandy situation, they did have a provider from Michigan pass away. So they're going to actually make a push to put that person on our wall as well. Other than that, that's the highlights. And then Dr. Daly did present us all on his Narcan, intranasal Narcan project.
Gotcha. I was planning on doing that under old business, just letting everybody see what we're doing with that as well. Thank you, Carol. Anything from the HOC? No meeting, Tim?
No meeting, no.
Okay. Agency upgrades, we're just looking at Skidmore College EMS and public access defibrillation. We've got a significant number of applications, which is great to see. Before we go into new business, what I'd like to do is there are new faces in the room, and I should have started there. What I'd like to do is let's go around the room just so everybody can say hi, introduce themselves. It'll be good for the people that view this on video to be able to know who everybody is, since Chris is having so much fun over there with the video anyway. But let's go around the room and all introduce themselves, if you don't mind. I'm Michael Daly. Let's start with Rich Beebe.
Jeff Williams.
Deb Cox. Carol Brandt.
Mary Reynolds.
Slow down.
Margo Manson.
Jason Burnett.
Jamie Barton.
Jay Conn.
Dean Romano.
Bruce Eschkow. Sam Bosco. Brian Taft. Ash Alexander.
Jonathan Halpert.
Peter Berry.
Ken Dot.
Matt Miles.
Michael Broder?
Eric Hanchett.
Don Doyle.
Steve Sequeiros.
Tim Arabli.
Scott Bowman. Paul Feltz.
Turn the camera on, Chris.
Chris Colt.
The man behind the curtain. That was great.
The
Thank
great
you,
and
guys.
powerful eyes.
Nice. Couple of things as we head into new business. There's been one major issue at Albany Med which Art has been working to try to track down the problems with. People seem to have found the EMS room at Albany Med to be a really good place to dump sharps containers. And so we have had this growing pile of sharps containers just turning up. Oddly enough, we actually have a community sharps disposal program. Every Saturday from I think 9 to 1, anybody can bring sharps containers to us. We'd be more than happy to dispose of them. We'll show people where to go. But we just rather, if you take back to your agencies, please don't dump your sharps containers at the Med. We don't need them. In terms of Remac membership, we welcome Matt Miles. Jason Bernard is also here. Who else is new to us? That's actually our only two new folks. Matt, what is your official title at Ellis?
It's the medical director of emergency care medical center department. Not long enough.
Moderately long enough.
Okay.
That's good. So Matt's actually former chief up in Glens Falls, where he was a huge partner at working with us in Mountain Lake. So that's absolutely fantastic. So welcome. And Jason is faculty up at Saratoga. So thank you. We were asked for a review of policy upgrades to ALS, and this was included EMT intermediate and paramedic programs. In particular, this is because these policies actually have not been updated since about 2006, 2007. Tim, do you remember? Anyway, a long time, a long time. What I'd like to do is just have a couple of people take a look at these policies, think about what needs to be done, if anything needs to change on these. I'd really just like 2 volunteers to bring it back at the next meeting. Okay, it's just like an auction. Dr. Bernard just moved his head, therefore he's a winner. Welcome. Excellent. One other volunteer, please. Oh, Dr. Sakaris moved his pen. Excellent.
Actually, I won't be here at the next one.
Oh, okay. So Dr. Sakaris will be excused from the next meeting. We'll make sure to add that to the minutes for the next meeting now. Okay. Another volunteer? I feel like I'm pulling teeth here. This is terrible. 12 minutes worth of work here, folks.
I'll do it.
Huh? Thanks,
You're
Tom.
going to send it by email?
Yeah. Okay. Thank you very much. For the next meeting, we'll be looking at a patella dislocation reduction protocol that Dr. McHugh is putting together, and we'll put that out for next time. One of the things that we're going to do to make it easier for us as we move to 2014, there are 2 things that will be changing as we move into the next set of protocol updates. One is that we're going to have to update the protocols. The other is that we've had a change in scope of practice in New York State to advanced EMT and paramedic, as well as the retention of the CC title and scope of practice in New York, which has been kind of an unusual process for the state. We're going to need to make sure that our intermediate protocol marries up with the scope of practice of the advanced EMT, and we're going to make sure that there aren't any additions to the protocols that we should need or any changes. What I'm going to do is write a survey that'll go out to all agencies to disseminate to their providers. What I was planning on asking, and please think about it for a minute, because I'm going to test drive this process on you guys, so you can try it out, see if it makes sense, and then shoot some comments back. But basically, asking any changes to the protocol, current protocols that it would affect, why you want to do it from a just thought process perspective, and if there's any evidence behind the reasons that you want to do it. And all of this will be dumped into a single file. It'll then be shared with the committee that will be working on the protocols. The goal being that hopefully we will have evidence-based changes to the protocols. We'll be able to look at the evidence along with the idea rather than just getting the idea and having to research the evidence ourselves. Because if somebody wants a change, they should be able to supply the evidence to why the change should happen. All right. Dr. Cushman has already started putting some things together. He's in Rochester. He's going to be adopting something that looks very much like our collaborative protocols, but without the levels in between. But he's already looking at ketamine for a number of different utilizations, as well as a expanded presumptive death protocol, both of which will be pretty interesting. We have one vote that needs to come up, which is for Sand Lake's new ambulance medical director. I have her CV in hand. Dr. Ushkow, do you want to speak to Dr. Weaver at all?
Dr. Weaver was trained at U of Pitt. She's been an emergency physician for many years with Remac. She's very experienced at pre-hospital care. She's been involved in flight medic work as well. She's married to a paramedic, so certainly understands and lives the life. And I would recommend her highly.
As an additional recommendation, I actually was a year ahead of her in residency, and she was a fantastic emergency physician while in residency, and she remains a close friend. So Dr. Ushkow brings this forward. This came from Sand Lake's request for their new medical director. She certainly will be welcome to all of these MAC meetings if she is voted in, as every other medical director is, but she works standing nights at Samaritan, and I think Wednesday afternoons will probably be tough because it's a sleep day for her. But we'll bring this forward as a motion from Dr. Ushkow. I will second it from the chair. All in favor of Dr. Weaver?
Aye.
Thank you very much. Appreciate it. In terms of old business, let's start with drug shortages. And let's start with drug shortages, specifically atropine, and some commentary from Dr. Broder. Anything to add? Any advice?
So I do have an article somewhere in my archives that you can compound atropine from bulk powder, which is available relatively inexpensively. It should be done at a compounding pharmacy, and unfortunately we know compounding pharmacies got a very big black eye recently with everything that happened at New England Compounding Pharmacy. So I need to look at the data to see how long it's stable in syringes at room temperature. But I see that as a potential workaround if we're not able to get the preloads from the traditional sources for the atropine. The dopamine, there's a time talking about norepinephrine. Some thoughts, very scattered.
Mm-hmm.
And I will look for that article right now because I believe it's somewhere looking here.
Gotcha. I know one of the things that some of the hospitals have started to do is use vials of 1 milligram and 1 ml of atropine, and some of the agencies have started to get that in restock. What I've asked for the hospitals to do is to see whether or not they can use their preloaded syringes for ambulance restock and use the vials on crash carts on the floor, because that way we'll maintain continuity in using things within the formula that we currently have in place, rather than have to come up with workarounds. We'll see whether or not that's something that's sustainable. Since we don't use that much atropine anymore in the pre-hospital environment, that should be a little bit easier to do. And hopefully that's something that will be sustainable. From a medicine perspective, making the jump to norepi would be a pretty heavy lift. We'd have to do a significant amount of education before we could go there. My first thought would be that should we be in a position where we have expired all of the dopamine, that the paramedic on board the ambulance could call and get a physician order for an epi drip. Not a drug that I want to see given to people if we can help it, but it may be the only thing that we have as an option at this point, without causing increased hazard. The reason we went away from a vial of dopamine and mixing our own dopamine drips in the ambulance is because we had seen a case of that given IV directly from the vial into a vein. So this was all about protecting patients from harm. That's why we went to the premix. And I know there are already squads that are out of dopamine, so it's just not out there. We went through EMS charts in 2012. Dopamine was used pre-hospitally and recorded appropriately in EMS charts 36 times. There may be a single utilization where it was recorded incorrectly in EMS charts. We're not quite sure of that. But 36 utilizations, every single one of those 36 was on board a LifeNet helicopter. It is not demonstrated to have been used in an EMS charts application for all of 2012. So I don't see that there is a potential harm to our patient population by just saying there isn't any dopamine, we're sorry there isn't any dopamine, call and talk to a physician if you need anything, and the physician can walk you through an epi drip. But that's my thought. Thoughts from the floor?
More question. What would be the hard lift with moving the Levoped? Is it doesn't come prepackaged and you have to mix it up? Levoped is a better choice anyway. I think it would be even if the shortage didn't occur, that's something I'd move towards anyway, is getting your dopamine and moving towards Levoped.
Frankly, I agree with Bruce. I think you're right. I think Levoped is probably the better drug, but since at this point that would be a complete formulary change, and it's not on formulary anywhere in the state, so we would need to bring it to the CMAC in order to get approval to use it pre-hospitally. It would be a lengthy period of time, and then we would need to get the education out there to the providers. We're probably better off just looking to an update, a protocol update, building that into the protocol update, and then moving away from dopamine into Levoped at the same time, rather than trying to do it now. A lot of hurdles in between.
Well, the amount that dopamine has been used, in total agreement. The one time I've seen it used, it was incorrectly used, so that's good.
We're not carrying it on any of our units at this time.
Mary?
Did the Arums folks forward you the list of their drug shortages issues?
They did. I was going to go through those as well. In fact, the atropine was one. Dopamine was another one. 1 to 1,000 epi, 1 to 10,000 epi was something else. We had already given them some information on how to fix that. And the 1 to 10,000 epi and the 1 milligram and 1 ml of atropine, the answer remains the same in terms of what to do. You package it with 10 mLs of saline and a syringe. You draw them up together, and you build the 1 to 10,000 that you need for the epi. It's a workaround again. If we can't get the hospital stocks diverted to the pre-hospital environment because we have less use of it. The other one that actually had come up as discussion in Arums has not been an issue here yet was Lasix being a shortage, and whether or not they should focus on switching over to Bumex pre-hospitally. My thought on that would be, we almost got rid of Lasix in the protocol the last time we went through anyway. If we run out of Lasix, we run out of Lasix. We can give it when we get to the hospital. I just reviewed a fascinating paper for pre-hospital emergency care, which will hopefully be published at some point over the next 6 months. The interesting take-home of this is 1/3 of the time Lasix was given to the right patients, 1/3 of the time it was given to patients who it clearly shouldn't have been given to, and 1/3 of the time it was given where it probably didn't do any harm or good. We don't have a way to look and see whether or not it's done similarly locally, but it's a physician option, therefore it's something we can follow through in the hospital rather than creating a substitution pre-hospital and additional expenses to the agencies.
I think years ago, we ended up substituting Remac for a period of time.
Mm-hmm.
We had talked about. That's one question that would come up, and I don't know if we need to make a statement somewhere. If you're not carrying the medication because it's now a shortage, you're technically not following the formulary that you're supposed to have as per Remo. So I don't know if we should put an exception in there.
Well, we had created a policy, and it's really important that we bring that up now, Don, so I'm really glad you mentioned it. If you're not carrying a drug because of a shortage, you're supposed to send a letter to Remo. So staff here can maintain a list of who's short of what, and that way we don't have, we're not missing any shortages. So the other thing that just came up that Jeff mentioned is that there's currently a shortage of carpujects of morphine, but morphine is still available in vials. So that's something which can be handled through a rewrite or an update to a controlled substance protocol just to make, or a controlled substance plan, just to make sure that additional way of carrying the drug is approved, and then you just move forward. That's just a notification to the department and nothing more complicated than that. And that was something that we looked towards with the ampules of fentanyl a couple of years ago when we moved away from ampules. Anything else, Mary? Anything else from a state perspective?
Fentanyl has to be in either an ampule or a vial. It cannot be in a cartridge.
Yes, fentanyl has to be in the ampule or a vial currently, but that was how it was handled, was through an update to your plan.
Any thoughts on, I'm just thinking out loud here, but EMS agencies to create like a buying group for medications, like hospitals have done in the past? It probably wouldn't work for controlled substances, I know there's limitations there, but maybe it's a naive thought, I don't know, but. So, like, in New York City, a lot of the hospitals get together and they create a buying group, and therefore they're able to leverage manufacturers and things like that. Unfortunately, if you're not a big utilizer of medications, you can kind of be blown off, as opposed to if you're a larger, you know. Food for thought.
Any comments? Agency bosses, any comments?
We have to bid it.
So, yeah, from a municipal agency would be, okay.
Right now, our shortages are, we have no dopamine, we're short on atropine, and we've had to order sucks from compound pharmacy.
Actually, Peter, if you want to speak to the sucks that we found, because that actually has been a benefit, oddly
You
enough.
probably know more about it than I do.
Okay. Basically, what happened when we got short of the succinylcholine, which is the temperature unstable succinylcholine that we are used to carrying, our assistant chief Fink, who's in charge of supply, went looking to find what was available through the compounding pharmacies, and found for about, I think it was somewhere in the neighborhood of 6 times the expense of the temperature unstable succinylcholine, he found temperature stable succinylcholine. Well, we don't use sucks that much. So actually this is going to lead to a savings for the agency, because the succinylcholine won't have to be thrown out. It'll be stable for a longer period of time. So it was an interesting piece of information to find, so we passed the information on to other agencies who use it. So just an interesting process. Has to be reconstituted. It's a lyophilized medication similar to vecuronium or others. And then let me share with you some information about the intranasal Narcan program. This is a program that I shared with the folks from the Medical Standards Committee, and frankly went extremely well. You guys were really, really helpful in this, getting this off the ground. The staff here has been fantastic with this. Basically, the OS Narcan program worked like a charm. So, why? Well, we started this because Remo was asked to help out Mountain Lakes because the folks up in Ticonderoga had seen a couple of nasty BLS-treated overdoses who'd done very poorly. Then we kept on going from there. Suffolk and Rochester jumped on right away to help us out with it, which was really nice. As we were looking last fall, through the winter time, Bon Jovi's daughter was nice enough to overdose to provide a little bit of additional notoriety to the program. We'll note that she overdosed in Hamilton College, where there is no basic life support naloxone program, but it helped towards our final answers at the end of the program. The partnership itself ended up being kind of complicated. We started this almost 5 years ago, 4 or 5 years ago. And we started this as a collaborative effort between the regions. Then we got involved with folks at the Department of Health and ended up doing this as a collaboration between the AIDS Institute, Bureau of EMS, Remo, and the Med. And what ended up happening as a result is it slowed it down a little bit, but the product that went out the door ended up being really good, with a training video that was done through the Hoax Corners Ambulance Squad over in Rensselaer County, and free intranasal naloxone setups that were distributed through here and then through satellite organizations around the state. The reason, pretty obvious. Basic life support shows up more frequently than advanced life support, particularly in areas of the state where there are fewer providers, which is really nice. And looking at the data out of Boston in particular, there weren't any hazards to personnel, which we really wanted to make sure. Took about 90 minutes for the training. I think, Chris, some of the training that we did was a little bit shorter. Probably took, when we went out to train Duanesburg before Camp Bisco last year, I think it probably took an hour.
Yeah.
Yeah, it worked out really nicely. Did a pre-test, post-test. People really were very accepting of what we did. The nice thing to see is that recognition of opioid overdoses was really good before we started and got better, and people's confidence at administering intranasal medications went up. Everything that we looked at in terms of progression through the training worked the way we were hoping it to. Everybody that looked at this product thought that it should be the scope of practice for EMT basics. Saved a significant number of folks down on Long Island. In fact, Suffolk County Police, I understand, are having a blast with this. So they actually had people going from one precinct into another precinct requesting, hey, are you a car with the Narcan? I need you over here. So they're actually jumping precinct boundaries in order to reverse overdoses, which is kind of interesting. So lots and lots of positive press on Long Island for this. Oddly enough, I read all of these articles as they kept on coming out. They kept on forgetting to mention that it was Remo's project. I thought that was very surprising. Ultimately, in 6 months of the training between June and December, we had 1,300 EMTs trained. We reversed 69 opioid overdoses. If you extrapolate from 6-month data to a full year, that means for every 10 EMTs we trained, we were going to get 1 opioid overdose reversal. To me, that's a just amazing success for a program that was this easy to put together. Relatively inexpensive all the way across the board. There was a really interesting complication as well I'll tell you about in a minute. Regionally, Suffolk did 52. Monroe, Livingston did 17. That was 25% of the total was Rochester Fire. 40% were Suffolk PD. Cases, guys overdose more frequently than women. 65% of the cases required just a single dose of intranasal naloxone, and they were breathing again, which was kind of cool. About 28% got more IV Narcan when ALS showed up. Hazards to the crew. This was agitated and aggravated patients. There weren't any physical hazards that were presented to any crews, and nobody got hurt. Agents ingested. If anybody's in the back doing math really quickly, this does not add up to 100%. All right. The reason it didn't is the things that were overdosed on once I didn't bother to write down as a list for you. All right. But mainly the thing to know: heroin 66% of the time. This was the complication. So the Suffolk County Police Department found someone in respiratory arrest, reversed the respiratory arrest, and then arrested him. That would be an arrest. Interestingly, then they reversed the arrest because this actually was in violation of something called the 911 Good Samaritan law. If somebody calls 911 specifically for the purposes of care for another person who is overdosed on drugs, they shouldn't be prosecuted for personal use items. So if someone's got a syringe with some residual heroin in it or a bag for personal use, they shouldn't be prosecuted for that. On the other hand, if there's anything else, a gun, an outstanding warrant, enough there for sales, this doesn't preclude cops from being cops and doing their job. This is just to make sure that people don't hesitate to call 911 for an overdose. And I've got to tell you, I was amazed at how fast this came up from the AIDS Institute, sent this out with a, what's going on in Suffolk County memo. I was on the phone to Suffolk County Police that afternoon. They had a memo out the following morning to all their patrol folks to come up with a solution to make sure they were educating their providers about this law to make sure they were doing a good job. Suffolk County Police hopped right on this right away and fixed it. I was very impressed. Conclusion, ultimately, is that this was a phenomenal success. What we ended up suggesting to the department is that the department continue to fund introductory programs. The programs that are already up and running, they're successful, they want to keep on going, they'll fund themselves. But if we were to have another large law enforcement agency or something that wanted to participate, suggest to the Department of Health to continue funding that because it's such a small amount of money for such a huge potential public health impact. The other two things that I suggested to the department, the first was BLS naloxone, that we look at BLS naloxone just like we do BLS albuterol. If you want to be a naloxone agency, send us a letter, we'll send you the stuff, and we'll stock you through here. That way, we continue to get quality assurance information. We know that your providers are going to be trained, and that way we can have control over what's going on in the BLS community, which is the best way to keep that data stream working well. The agency was considering that. The other thing that I suggested was public access naloxone. In particular, this would be for agencies like Hamilton College's public safety agency. If they find out at Hamilton College that they've got a significant problem with opioid overdose, it may be a good idea for them to train their security guards in using this the same way they do. They train their folks in public access defibrillation. So using the same model. The department saw this, thought it was a pretty good idea, but they're actually going to suggest they just change code in the regulations around the the Friends and Family naloxone program to include agencies that aren't within the public safety within the public safety or EMS model. So some different things that we learned and where it's going to go. So thank you. This was, by the way, left as a demonstration project after my presentation at the Medical Standards Committee. They voted to move this into scope of practice for BLS providers. That motion came forward as a seconded motion at the CMAC, and there was no longer a quorum at the CMAC at that point, so it couldn't get voted on at the CMAC. Oddly enough, that's probably not all bad, because since it wasn't taken off pilot project status, that means the department is continuing to fund it at this point. So, interesting give and take on that. Any other thoughts, questions, concerns? John?
Hey, item. Could you revisit what occurred at the end of last year? I received an email on December 28th relative to the Town of Bethlehem Consolidation Program. There was an email vote on that process, and there was no discussion, obviously. Can you go through what exactly transpired regarding that?
I don't have, do you have the text of the email vote, Tim, just so we can make sure we can get that? Because you're right, it's an email vote, it should be
Well, that was a pretty major item. I mean, that was, a new agency was created, and it was created without any kind of evaluation by this body. And I was concerned about that. I don't know, I'm a town resident, I don't know a whole lot of the details, specifics in terms of the evolution of that new organization, and I think that no one here, with very few exceptions, perhaps Bruce, who's servicing the group, and yourself, really is quite that aware of it.
Well, the vote itself, just so everybody in the room knows what that was, what John's talking about is Bethlehem EMS and Delmar EMS merged into a single agency, Bethlehem Delmar, or Delmar Bethlehem EMS. Our email vote was, and I will read exactly what the text was at that, was by resolution, the Hudson Mohawk Remac endorses Town of Bethlehem Ambulance Services implementation of EMT adjunctive care, including albuterol, epinephrine, glucometry, and further supports provisional approval of the applicant with operational ALS authority at EMT intermediate and paramedic level. What this was pertaining to and specifically was all of those adjunctive elements of care that are needed to be approved here. This was more academic than anything else in terms of moving it forward. The merger of the agencies itself didn't have to come before this body. The merger of the agencies was something that occurred internally and doesn't have MAC oversight. The only thing that had MAC oversight was the other stuff that they were already doing. And that's why that needed to come here, because the department needed that in order to approve the final process. Does that make sense?
It does.
It was very hard for me to figure out while it was going on.
Did it need to happen on December 28th in terms of the scheduling for a January 1st implementation?
Yes.
Why?
Request of the Department of Health. Request of the Bureau.
I'm confused. That's not happened to us before.
This actually has never happened to us before.
Right.
We haven't seen the merger of an agency.
Right.
So this was actually something new for the department, because this isn't something that happens that much. They were trying to figure out the pieces as well. And while they were figuring out the pieces, they realized that in the approval process, one of the things that comes forward is, what levels are you operating at? And they checked off the boxes that they were previously operating at, which the agencies in the town were operating at BLS albuterol, BLS epi, glucometry, and when they started checking off those, they realized, oh, all of those have to come here.
Right.
And Delmar was operating at the intermediate level, and that needed to come here. And in order for the two to be put together, the piece of paper had to be finalized before the state would approve it for a January 1 operation.
Could that have been brought here in December or November?
It could have, if we'd known it would occur.
Because that's a large
Yeah.
conversation you're describing here, and we had no conversation about it.
Well, I certainly agree that it should have been brought here earlier. Unfortunately, it wasn't brought to my attention until December 27th.
Why did it need to happen for January 1st then?
That was the date that it was being implemented.
That was the town's decision.
That's the town's decision.
That was the town's
Because I can tell
decision.
you, December 31st, I was inspecting every ambulance.
Right.
Did they apply for a new CON?
Huh?
They applied for a new CON?
Muni, they want Muni.
Oh.
I think it's problematic for discussions of that nature to be brought to this body in that fashion. I don't think that email votes are necessarily applicable or appropriate for something of that magnitude for this body to consider. I don't think that the lack of discussion is a positive thing for us to be embracing in any sense when it comes to that kind of an item. I don't have a dog in the fight. I don't think there is a fight. In fact, from everything I've talked to other people about, it sounds like a very positive, proactive move for the town, and probably one that I would myself personally endorse. But I think that the mechanism by which it was brought forward was inappropriate.
I think that makes a lot of sense. And frankly, I agree with you. I want to make sure that everything that we do here, whenever we have an opportunity, has every opportunity for discussion. We need to be having discussions. Look at the number of people we have in this room.
Right.
This is an inclusive body, and that's something that I think
This
we've been
particular
really
topic
good
is
at.
the kind of thing this body should really have both hands deeply within.
I agree.
Okay, so now it's fait accompli, that's fine. Can you expand upon this? Normally, the officers of the different agencies come in, explain their decision-making process, the thought process behind it. This was brought forward through the mechanism of the Town of Bethlehem's Ambulance Oversight Board, what's the name of it? The Ambulance Commissioners.
Yes.
The information is posted publicly online through the town's website. You're part of that group. Can you expound upon the history, the detail, and what the overall goal is going to be?
Overall goal of this process, as frankly I think we should be doing quite frequently, is let's watch how we're doing the job and make sure if there are ways to do the job better, we do. What happened with the Town Ambulance Board in Bethlehem was we asked for deliverables, reviewed the process of care that was going on in the town. For those of you that don't know, the Town of Bethlehem has 3 transporting agencies, 4 if you count the Albany County Sheriff's Department, and a single provider of advanced life supports, the County Sheriff's Department. It's a interesting system. It's been operating for an awfully long time. It has a combination of paid personnel and also volunteers. I'm speaking as a member of the Town Ambulance Commissioners. Bruce sits over there. He's a member of the board of Delmar Bethlehem Ambulance, which is the squad that was formed. And Bruce, feel free to jump in at any point.
People are doing great.
But basically what ended up happening is looking at a series of objective deliverables, the town ambulance commissioners sat down with the agents themselves who were getting tax funding for their squads, a significant amount of tax funding, and said, we've got a lot of redundancy. This just doesn't make sense to be spending this much money on agencies doing the exact same things. Let's make this one agency. Let's write one contract that we can take care of from here. And the agencies got together and built a single new agency that is basically probably one of the strongest boards that I've seen in a long time. I'm really impressed with the group of people that got together. Very professional management team, a fantastic relationship with the Albany County Sheriff's Department, who does their daytime staffing and does their provision of ALS, and will hopefully be providing a product with less redundancy and better provision of service, better oversight, and ultimately better care for the residents.
The only part that I would add to that, you sort of use a past tense term where we've overcome some hurdles, but this is clearly still an evolving process. We've merged the name, we've merged some of our processes. There is an awful lot that still needs to be done, will continue to be done over the next several years. So it's a process in evolution. I agree with you that it was sort of pushed through at the last minute from everybody's viewpoint, and that didn't make anyone happy, and that shouldn't have happened, but it did happen.
So it will likely happen again for other situations, I assume.
Hopefully not for this agency, now that we have a supervisory board that didn't exist until after
No, in
January
terms of
1.
precedents that are continuing to set.
Well, which part of the precedence, John? I mean, if you mean, will the entire process of agencies merging exist again? No. Will something like this come through again, where we've got a request on the 28th for a vote to make sure that we can do glucometry at an agency that didn't exist on the 27th and will exist on the 1st? I certainly hope this doesn't, because the state now knows the process well enough to be able to hand the right pieces of paper to the people that are
Since the
following
Board
it
of
through.
Commissioners minutes were posted from the September meeting declaring that this would occur by January, it should have been brought to this board well before December 28th via an email, that process.
Well, the process of merging an agency doesn't need to come to this body. As an informational item, certainly, but doesn't need to come to this
But if
body.
the detail of merging requires portions of it brought to this body, it does happen.
Actually, the parts that ended up coming to this body didn't come to my attention until the 27th. I can't say anything other than I'm sorry.
Okay.
I wasn't a part of the process of doing the merger or making sure that all of the pieces were posted until on the 27th or 28th, I was handed oh my God, we need this by the Department of Health, or the ambulances are going to be in violation, which is why this came out.
So it was
You know,
a
why-
colossal misunderstanding.
Why all of the pieces didn't fall into place the way they should, I can't give you a good answer. Why some of the things that the Department of Health requested weren't requested until the last minute or didn't appear in the initial application, I can't tell you that part either.
Okay.
Any other questions? Mary, anything else to add?
No, I can tell you that a lot of agencies, especially with a lot of this, the latest trend of using CONs, have encountered occurrences like this. Narcotics. They can't get narcotics until they already have an agency code and all the paperwork. It's a chicken and an egg dilemma. When do you give them the number? When do they get their approvals?
Or do we wait until they get a permit?
Correct.
Yeah.
So, I mean, I can see both sides of this argument. Unfortunately, there is no easy solution. You know, unless you guys as a board were to say, we're gonna grant provisional approval for this entity, whatever it's called in the end. You know, there is no easy way around it. I can tell you that December 28th, well, who's gonna get stuck with this one? With the same thing going through our office, you know, when this goes through.
And the other thing, just as a matter of conducting the business of the day, we had talked at, I want to say it was just in the December minutes, since somebody's got the December minutes in front of them, about doing email votes in case there was a crisis like this.
So that was convenient, in fact.
So, it was good. And actually, what I thought it was going to end up pertaining to was a drug shortage. So. Anything else? Old business, new business, motion to adjourn.
So moved.
As an-
Has there been any more talk about the FE 1-1000 pilot for EMTs versus auto injectors?
No.
Just
I
out of
put
curiosity,
the-
What's Mohawk spend a year in auto injectors?
A lot
A
of
lot.
money.
It's $8,000 for us.
A lot. We've got,
Put the request out to the Department of Health along with the brief overview, and not interested right now. Without the interest of the Department of Health in supporting a pilot project, we can't carry it through. All right. Chris?
One of the things that you guys had requested is that we get some of the old timers together, and we actually did that, and we have a video. It will be up on the website within the next 24 hours. It is on a YouTube channel for Remo EMS. It's about 45 minutes worth of content. If you YouTube search Remo EMS, you should come up with us. That's where all these meetings are posted and then up to our website. It'll be there tonight.
Awesome. Thank you.
And I'll start it when we're done here.
Thank you very much.
So it looks like atropine powder, when reconstituted at stability of about 4 weeks at room temperature. When I priced it out a couple of years ago, you get yourself a big bottle of atropine for about $8. So, not a lot of money. So you just need to find someone that has a sterile hood, like at the college of pharmacy, that can make a bunch of stuff for you.
Is that an official offer, Dr. Broder?
Let me check with my supervising pharmacist. I'm writing checks that probably we could, but no, we shouldn't do that.
Depends how it's listed on the formulary. I know Aram's the discussion came up, they were willing to jump right on Bumex, and they came to a screeching halt when we pointed out that Bumex was not on the state formulary.
Well, it would still be the same exact thing as opposed to just being commercially prepared. It would be prepared by a compounding pharmacy. So it would be the same strength, it would be the same drug, it would just be the method that we procured it.
One of the interesting discrepancies that we will continually have, Mary, is the fact that Bumex, for example, has been used as an approved substitution in the state in the past. So whether or not it's on the state formulary, it has already been used in precedent. And that becomes a very interesting
I mean, I
discrepancy.
think we did it here in like
So,
2003
we
or
did.
something.
We did. It was, I want to say it was 2003. So, it's been there, it's out there, and it's one of those things where if there's something we need to do to keep the wheels on, we're going to need to do to keep the wheels on. But this isn't one. So. We have a seconded motion on the floor. All in favor? Thank you.